Hi, and welcome to Complex Coronary Cases from the Leeds General Infirmary. This is a case of retrograde PCI for a right coronary artery chronic total occlusion. I am Dr. Abdul Mozid, and this is a case I proctored with Dr. Steve Lindsay, consultant cardiologist at the Bradford Royal Infirmary. So this is a 47-year-old man who presented with CCS class 2 angina symptoms. He was found to have inferior ischemia on perfusion imaging. A CT coronary angiogram showed a proximal RCA chronic total occlusion. The right coronary was seen to arise from the left sinus, but with a non-malignant course. He underwent an unsuccessful attempt at the local hospital at Bradford and was referred to myself for a second attempt. This is his diagnostic angiogram from the previous procedure. This is the left coronary artery showing retrograde collaterals to the RCA. This is predominantly from an apical collateral from the LAD, which is very tortuous. There do not appear to be clear septal connections. There is a distal septal to an RV branch. Here is the right coronary artery showing a aberrant origin from the left sinus. The occlusion appears to be short. However, the proximal cap is very ambiguous and the distal vessel fills by bruised collaterals. Here you can see it is very unclear where the proximal cap of the occluded segment is. So he was referred for the second attempt. This procedure was performed with left radial artery access. The right radial was occluded from the previous attempt, so he had right femoral artery access for the second access. These are his images from the left coronary, again confirming a dominant apical collateral from the LAD. There is also a distal septal, which appears to have an epicardial course and connects to an RV high marginal branch. There don't appear to be clear septal connections. So we attempted briefly to try and engage the right coronary artery, but this proved very difficult, in fact. So this was an Amplat left one initially. Again, it was difficult to try and engage the right coronary artery initially. We can see non-selective images demonstrating the right coronary artery, but again, it was difficult to wire and integrate. So we tried a couple of different catheter shapes and tried to free wire the right coronary in the fishing technique. This was not easily doable. So rather than persist and waste time and effort trying this, we elected to go directly to a retrograde procedure, given that we would probably require to go retrograde anyway to clarify the course of the vessel. So here are the setup images again. There is a dominant apical collateral from the LAD, which is highly tortuous, but potentially usable. But as always, we try and use or at least try and attempt the septals first, as these are much safer. So again, there does not appear to be any clear septal communications. But nevertheless, often it is possible to cross septals even when they are not clearly visible. So we used a whisper MS just to engage the septal. This is a turnpike LP microcatheter engaging the second septal. And then this is brief attempt with a Xeon wire. And this is a case of doing septal surfing, trying to see if we can cross. We often try septal surfing first, so blind surfing to see if any connections. If this proves difficult, then you can move on to performing a tip injection. The downside of tip injections are occasionally dissecting the septals, rendering them not possible, rendering them useless for crossing. So here, there's not appear to be, it's not an easy channel into the PDA. So to get the injections, just to clarify where we were. So we needed to come back and redirect. So this is the Xeon wire. Showing the right direction, but not quite there. So brought back and rotated again, and there we go. This seems to have crossed into the PDA. This is confirmed with contrast injection. It's always important to confirm the position before advancing the microcatheter. And ideally, this should be performed in two different views. So here we check again, now in the LAO view, having wired the septal in the REA view. And this shows that the wire is nicely into the distal right. So we move back to the REA view to advance the turnpike LP. And this is rotated, can be counterclockwise or clockwise or a combination. And here is making slow but definite progress. And so we are into the distal right. So this is a good teaching point in that even if you do not see clear septal communications by angiogram, it is always worth pursuing these and trying septal surfing rather than attempting a high-risk epicardial. So this is really reassuring that we've now managed to cross retrograde via septal. The turnpike LP is now advanced up to the mid-RCA towards the distal cap of the occlusion. So once the septal is crossed, we can now go to the LEO view now to try and cross a proximal RCA. Mid RCA, the wire appears to take a slightly unusual course. So here we brought the microcatheter back and took a tip injection to clarify the course. So this is using a 2 ml lock syringe. It's important to aspirate until you get blood into the syringe to ensure that the catheter is not damped. Microcatheter is not damped, which may lead to dissection. So once you have blood aspirating, then you can inject. So here's a tip injection showing, in fact, that actually the retrograde wire was probably deviating into that small side branch. And in fact, we needed to take a more straight course rather than deviating to the side. We checked this in a different view also. You can see the microcatheter is at the distal cap. So we then, from this point, took a pilot 200 wire to try and bypass this channel and to cross the occluded segment. So here with a pilot 200, and this takes a much more reassuring path. It's important to try and feel for resistance. Those are probably some more branches. Microcatheter is an advanced. The strategy is now to try and wire the occlusion rather than forming a knuckle to form reverse cuts. If we are unable to wire the vessel easily, or it becomes ambiguous in terms of crossing, then yes, we would push the loop to form a knuckle and then come antegrade with antegrade equipment to overlay. But given the occlusion length is short, there is a good chance that we should be able to wire this true to true. So here, this is a slightly more resistant point, and drilling here with the pilot 200 is now making more progress. It is now clearly making progress through the RCA. I'm just checking the REA view that we're happy This looks good. And here we are again, just drilling with the Pilot 200. And we are nearing the likely ostium. The wire is likely being gripped by the occlusion itself. It doesn't feel entirely free yet. But with a bit more push and drilling, you can see the wire now is free into the aorta. You can see the motion of the wire, which clearly demonstrates that this is in aorta rather than being subintimal in the wall of the aorta. So now the plan is to advance the microcatheter also out into the aorta in exchange for a long RG3 wire and try to snare this. If the right coronary ostium was in a more classic position, we could have now engaged the antegrade guide catheter and tried to wire the guide catheter. This, given the anterior origin, we had already spent some time failing to engage right, so we felt that snaring would be the most efficient method. So here's the RG3 wire. So we put a umbrella shaped bend on the tip of the RG3 to make it easier to snare this wire. Then this is a 7 French GR4 guide with the N snare. And this is a dual operator process. One operator tries to bring the wire back, tries to advance it through the snare, whilst the other operator advances and withdraws the snare, trying to capture the wire. So here we are. Unsuccessful the first few times. So it's just a case of then changing the position of the snare, advancing it either more towards the proximal aorta or withdrawing it to the arch. So it's a case of just changing positions. You can also rotate the guide catheter to try and give you a different angle. So here we rotate the guide catheter, rotated the snare, and there we go. Now it's pulled into the guide catheter, and this again a 2-operator process where one operator pulls out the snared wire whilst the other advances the RG3. You can then pull tension on the wire to advance the guide into the root. Once we then have the wire, we can then withdraw the retrograde turnpike LP over the now externalized wire, and we then advance a guide liner to perform the procedure, leaving the 7 French GR4 guide well out in the aorta. So this is then a 2.5mm balloon to dilate the occlusion. So we withdraw the retrograde myocatheter some more. It is important when you're withdrawing the retrograde myocatheter to keep a very close eye on the retrograde guide catheter, which can be sucked in. It's always important to try and have this hanging out into the aorta also over the externalized wire during this process. This is a basic principle of retrograde PCI, but very, very important. So here we're dilating the tract, and you can see that the GR4 guide is hanging well out, and we're using the guide extension to actually engage the right coronary artery. The occlusion segment is pre-dilated. And given that we have likely taken a true-to-true course, we can give some contrast here now. To assess the artery. So actually there's a long segment of disease. So pre-dilate a little bit more distally as well. And here we are then passing an IVUS catheter to assess the length of disease that needs treating and to ensure that we accurately size the vessel. And also we use the IVUS to clarify the ostium of the RCA, which we have identified here. It is important to, as with any of these TTOPs, to get an optimal result using IVUS guidance, particularly for this sort of vessel where it's very difficult to re-engage for future procedures. So it is key to get the first procedure absolutely perfect. So in fact, on intravascular imaging, we had to extend our stent quite distal. So this is two 3.5mm by 48mm stents. First one deployed mid to distal, proximal to the bifurcation. Second one deployed on the ostium, overlapping with the first stent. After stent deployment and optimization with a 4mm NC balloon, then gave intracoronary nitrate, and this is the result in the RCA, showing a very nice result with excellent flow in the distal vessel and good size stents. So the next step is then to retrieve the retrograde equipment. So it's important to advance the microcatheter into at least a stented segment or ideally into the guide extension or guide catheter. Following this, the RG3 wire can then be pulled, and then this is then the final result in the RCA, showing an excellent result. We then take a picture of the left coronary system to ensure there's not been any damage to the collateral. And this is the reassuring angiogram of the left coronary artery. So thank you for joining us for this case presentation.